right at the moment, but Letty is going to take hers. Letty, thank you very much. This is all different kinds of artwork done by people with Alzheimer's disease.
Round of applause for Letty.
Sharon Rice, did you make it back with us this afternoon? Sharon, I think she does have some colleagues that she said maybe you could take hers. Fabulous.
Thank you, Sharon.
And last but not least, can we please give a, well, not last but not least, but on committee members, can we please say a huge, huge thank you to Esther Fuentes from
Esther, thank you.
When Dr. talks about Renaissance, for all of the incredible hospitality that we've had today. That is great. We cannot thank you enough.
And I'd also like to thank the other planning committee members, and along with Joseph Harris, the technical operator, John Garza, the director of this facility, and Hector Reyna, who is also an assistant. Thank you very much, Hector. And is that?
We have one more.
Two more? Okay, real quick.
And he's also contributed other publications about Latinos and mental health. Let us welcome Dr. Gonzalez.
This thing on? Well, good afternoon. My name is Dr. Gonzalez. I see a few of you participants here. I've worked with a few different students and some other colleagues, and one of my students said, "I'm looking forward to your jokes." And I said to her, "They don't know that about me." Well, one of the things I used to do in my previous life, I like to say, was I was a stand-up comedian. Apparently, well, you can tell how good I was because I'm here now. Thank you. And one of the nice things was, when I lived in Austin years ago, I would do the funniest person in Austin contest to try to be that. The first time I called to see what time am I on, and they said, being that there's 16 people each night, they said, "You're the headliner." Which normally you would want to be the headliner in a comedy club because that means you make the big bucks. Well, in my case, it meant that I went last. And so today I'm your headliner. And of course, you're staying for the prizes and the CEUs, not necessarily me. And you just got, some sugar, so that means you're good for about 30 minutes. So those are a few of my jokes. Let's see, I'm just originally from Corpus Christi, Texas. So not too far from the valley, but sometimes far enough, I don't know. A couple different worlds, but both pretty cool. Of course, Corpus Christi is the hometown of the Whataburger. Yes, New York has Broadway, New Orleans has jazz. We have, well, the Whataburger. And then we have Whataburger Field, so anyway. But there's no Whataburgers there. Anyway, on the field. That's terrible. Yeah. Well, see, and a lot of y'all now are pretty much tired enough that, it's going to be funny. The other day, my wife, I got married last summer, and I was, I think we went to go get some fried chicken for dinner. And I brought it in, she took it out, and she said, the chicken, it's getting smaller, Looking at how the economy's kind of down, right? The legs are a little bit, shorter. The thighs aren't so thick, and we only got to check, the legs and thighs. And I said to my wife, I wonder if the chicken breasts have lost a cup size. Anyway, it's bad. Okay? I still write comedy. I don't necessarily perform it so much, but of course. Maybe we'll see if it's appropriate or not, but we'll tell it anyway. Of course, last month, for those that are Catholic, there was a new Pope elected, so which was kind of cool, Pope Francis, and he actually I did hear this today, this is actually serious, he did talk about something about holding priests accountable as far as sexual abuse. But anyway, so when they announced that, there was all this excitement, when there was the white smoke, and then they announced him, and I was watching the news that evening, and there was a report about all, different people were just happy, and they went to this one religious store to interview the owner, and the owner was excited, about getting the new Pope stuff, and normally the bookmarkers are the really popular things. And then I thought, well, what happens to the old Pope stuff? Like, is the Pope Benedict stuff, is that on clearance, or half price, or, I went in to go get a shirt, anyways, that's, so we're here today to talk about ethics and service delivery. This is a nice layout for a room. It's not even. And I have like either the minorities here, and y'all are the majority because there's more of you. Or it could be the other way around because you're closer to me and those people over there are like, y'all are like in San Juan or something. Anyway. But when we consider diversity though, you consider the Valley. I believe that the Valley, I don't know the actual numbers, but for the most part the Valley's very much Hispanic. At least 90% I believe, something like that. Now, when I say something like that, and I'll just put this out there because I don't know the answer to this, but if the Valley is 90% Hispanic, do they have power in the communities? And more than likely, sometimes they don't. Okay, a lot of times power more comes from money than from just representation. But what we have now, of course, in our country is we do have a lot of diversity. There's a lot of diversity in the Valley. And one of the big things that all of y'all are charged with is communicating with your patients. But not just telling them what to do, but making sure that they understand what you're telling them. And really that's one of the biggest things I'll talk about as we go through my presentation. Now, I want to know a couple of things because I see a lot of blue shirts or smogs. And I don't know if y'all are a gang or wearing the wrong color. It's like they're like the Crips or something. So now, how many? Okay, so by hands raised, how many? Let's start with social workers. How many social workers are here? Okay, let's see. How many nurses are here? Okay. Let's see. Okay, should we clarify? Let me be diverse with the nurses. How many RNs are here? Okay. LVNs. All right. Let's see. Any CNAs? I've identified the gang. To seek help as well as the help that is supplied in response to such efforts. So it's like whoever they come into contact with when they're distressed or need help or ill, along with also the response of their family caregivers to get to us. Okay? It's okay, it's not mine. My watch is okay. But there's a way that patients take to get to us. It doesn't always start formally. A lot of times it'll start informally. A patient will notice something about themselves is going on. They might talk to family, and family will say, oh yeah, well Uncle so-and-so had that, so this is what they did. So they do that. Or a lot of times, of course, in the family, this is probably not new to you, is if there's a medication that they might need, well, so-and-so had it, so then I identify it, so I just go across to go get it. But I don't go to the doctor yet. Okay, these are all the efforts that happen, that go on with the person before then they finally just realize, okay, that there's not, the efforts that they're putting in so far aren't working. So now it's time to start the formal stuff. And it might start with a primary care physician. It might start with an emergency room visit, well, including hospital stay. It might start with any of those things as to then getting help. So all along the way, whoever they come into contact with, along with whoever their family comes into contact with, are really important in them getting services. Okay, in them being, and the way that they're treated along the way is going to make a really big difference, not just in them getting better, but them in them learning that this is a better way to deal with illness, as opposed to just doing it the old way by listening to family and just doing that. Does that make sense? Okay. When I present normally, I like discussion, so you're welcome to yell out a question even before we get to the question and answer session, by the way, or at least write it down, because it's I just think it makes for a better discussion. So now, in order to get minorities to walk in the door for treatment, the treatment services have to have two characteristics. One, they have to be accessible. Patients have to get to us, or we have to get to them. And then once that happens, whatever we do has to be acceptable to them. Otherwise, they're not coming back. If they don't feel that they're understood, they're not going to come back. If they don't get it, even though they tell you they did, they're not going to come back. So that's another thing that's really, really important to understand and keep in mind. Okay, that was my watch. Yeah. So now, there are some barriers that ethnic and racial minorities have faced as far as in accessing health care over the past few years. There's economic, being able to afford it, administrative with how services are delivered, and that's one of the biggest things that we're here to talk about today. Cultural, in not maybe recognizing, or their culture not being recognized, along with communication. So within these includes language and the language that we use. Is translating things enough to help somebody that can't read English? Well, what if they don't read Spanish either? And along with the grade level that we would want it to be in. And possibly, and I was having this conversation earlier with a couple people outside, along with maybe the region, the terminology of the region. Is it okay to not be formal in Spanish, but to also add a couple of terms that are Tex-Mex, because at least then they realize, hey, you're speaking my language, as opposed to you're not. A lot of these things have led to a distrust of the delivery system, along with, of course, unfortunately, socioeconomic status being low and education levels being low. So those two things are harder to combat, but there are some things that we'll talk about that will help us hopefully make things more acceptable for clients. Here's a few different definitions of what culture is, or has been defined. In the Surgeon General's report back in '99, culture was defined broadly as a common heritage or set of beliefs, norms, and values. And that's pretty good, but still kind of general. So now the Office of Minority Health, the next year, defined culture as an integrated pattern of human behavior that includes the language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. And what NASW did, that's National Association of Social Workers did, was they added culture is often referred to as the totality of ways of being passed on from generation to generation. Now that last part, I think, is something really, really important. We learn what we learn from our families. And what we're going to probably do with our children is teach them what we know. So that's the whole idea of it being passed down. We rarely question, well, are we doing it correctly? Because what we're doing is what was done for us. Now, we might along the way modify things, and that's what we might do for ourselves. But either way, we're still passing something on. Now, one of the things I forgot to preface, that I meant to preface before I started, was that I am a social worker, and a lot of stuff I'm not in here, a few things I'm going to refer to social work. That doesn't necessarily mean it doesn't apply to everybody, though. Okay, any things that I talk about that might come from NASW really do apply to everybody, because we're all, in a sense, doing the same kind of thing with patient care. So I do apologize for not adding stuff from nursing. So I'll improve that. One other definition. Culture is the means by which we receive, organize, rationalize, and understand our particular experiences in the world. That's how it's a central element to our cultural patterning and our story and narrative. Now, when a lot of y'all work with older adults, I'm gonna assume, now, when you ask your clients, when you're doing your assessments and stuff, when you ask them questions, do they just give you the answer? No. They give you the story, and that's important to them. Now, your answer is in the story, and a lot of times in the story, you probably get other answers too, to other questions on your assessment, which is better just to listen. That's why it's good to really know your assessment, so that then you can fill it in. But listen to their story, because what happens if you stop the story? Yeah, they stop too. Now they're disrespected, and it doesn't matter how much coffee you're going to drink, because that's how a lot of times we communicate. I always have to stop myself because I do that. I'm like, ugh. Already I'm communicating in story. I'm going to take that as good. I don't know yet. So culture is more than just language or shared ethnicity, but it's shared values, expressions, it's thoughts, beliefs, meanings, traditions, and maybe even more than that. As we continue in what's going on with a lot of things that are going on in our world these days. It's even more. But what it helps is as far as with when related to mental illness and mental health, culture defines our patterns. It defines our ways of viewing the world, and it shapes our perceptions. It sets the stage for how it sets the stage for how and what people believe, and how they behave, solve problems, and communicate. Some of the examples I talked about earlier with how some people in the valley and some people just almost, not just from the valley, from other places, might cope with illness is what they learn maybe from somebody else. So that's what you do. Cultural influences the way we experience mental illness. Now, is mental illness, is there still a stigma? Really? Okay. And it's like, can somebody be depressed? Can we? Yeah, we can be depressed. But I don't want to be diagnosed depressed. My son look up. You're not crazy. You're just sad. And that's okay. But there's a big difference between both. That unfortunately sometimes in the communities we don't know yet, or it's not out there yet. Now, I put this slide in there, and last night I was realizing, well, why did I put this slide in there? Well, one of the first quotes I talked about with the sequence of how we get to treatment, or how we might work that actually comes from two gentlemen, Robler and Cortez, who've done lots of early work on service delivery. And another service delivery model that's been used in research Anderson Newman did a couple models that just explain everything that goes in, all those contexts I talked about. Well, what Kleinman did in 1980 is he did some cross-cultural work in China. And his questions, his basic idea is this: clients have a way to explain what's going on with them. We have a way to explain what's going on with the clients. And it's understanding the client's model, their explanatory model, and then there's the professional model. So where does our model come from? Probably from our education. And where does their model come from is from their experiences, from what they have learned, from all their education, from family, whatever they may watch on TV, and maybe what comes from their culture. So in order to treat somebody, and what his basic premise is, there's a negotiation with the client in understanding their model, and we understand our model, so that they can understand parts of our model to integrate into their model to get better. Does that make sense? Did I just lose me? But it's on us to understand that there's a way to introduce our concepts to them and that we can learn them. They may have their own terms, so we would go with their terms instead of our terms. Even though we know that we have our own terms, but do we have to always stick to our terms? No. If it's going to work for them, then that's probably going to be better. Then what I don't have to write down is that the client was resistant when the client didn't understand. That's true. I thought, well, that's the easy way out is to write client was resistant. But is it about them understanding us or us understanding them? In the past, it used to be about the patient not understanding what we were doing. Well, over the last few years, we've realized, wait a minute, maybe we're the ones that are at fault in not understanding the client in delivering our service, in being able to help them. So it's not that they didn't want help, I just didn't either know how to help them, or I wasn't flexible enough to be able to help them. So that's part of what we would want to do. So that's where I decided to leave this slide. A transition slide. I was looking at it like, oh, let me put this in there, because if I don't, it's like there's a, like I go from that to, okay, let's talk about ethics. Like, whoa. And I need you to be on a roller coaster, you know. So now ethics. We look at, okay, values are concerned with what is good and desirable. Now, ethics are concerned with what is right or correct, or right and wrong. Oh, by the way, if you have disagreements, anything, please let me know. Or have you escorted out? No, joking. Well, after we listen to you. Now, professional values are the values proclaimed by a professional group such as social workers or nurses. Social work professional ethics are based on the fundamental values that include worth, dignity, the uniqueness of all persons, as well as their rights and opportunities. So it's about the person. When we look at this here, their worth and dignity, and we consider the examples that I just gave y'all about trying to fit a client into our stuff, are we honoring this? And probably not, is what I would think. So in learning more about our client and learning more about their language and about what's going to work for them, then we're honoring their uniqueness and their rights. Okay, how did Rubio do it? Was it over here? Okay. So now with social work, and again, this might necessarily not just be social. Some of the core values are service, social justice, dignity and worth of a person, the importance of human relationships. This right here, I think, is something that's central to everything that we do. If we're not able to form a relationship with our client or patient, then that's going to really make it harder for me to work with them. Okay? It's going to be harder for me to do my job, whatever that might be. Whether it's giving medication, whether it's doing physical therapy or psychotherapy, or just trying to give them a bath. It's going to make it that hard. Integrity. Incompetence. And we'll talk more, not just about competence in our job, but what we'll talk about in a little bit is cultural competence also. So we have personal values. And these are the values that we have that are held by every person, but the same values, not everybody has the same values. We all have different personal values. And the hope is that we have, how can I put that without being judgmental, how can you, or should I be? That we would have, let's say healthy values. I'll say it that way. Instead of saying good values. Because do we know what might be good values for some might be good values, so another person might have a different set of good values. But I would think healthy values, I think, would be a better thing, or at least a good start, I believe. But again, that's still up for argument or discussion. Essentially, as long as you're not going to jail, that's pretty good. Put it that way. So now, again, I think I talked about this as far as with ethics. It's what people consider right and wrong. Ethics are standards that direct one's conduct. And I believe, now, let me make sure. Everybody in here follows some sort of code of ethics, correct? Okay, good. Okay. Well, you know, y'all too over there, right? Y'all follow a code of ethics. Okay? I don't want to leave you out. All right, okay, good. Levy had a couple of definitions from a while back as far as ethics. He called them values in action. And when we look at, we consider our professional values, those would be our values in action. And that would be ethics. Behavioral expectations or preferences, or our responsibilities. So those are some things that in following our ethics or being an ethical helper, I'll say, it would be all of these that would be part of that. In conducting the way we conduct ourselves, what we put into action, how we behave, or how we prefer to behave, or what our responsibilities are, would also be something that would be really need to keep into account. So professional ethics are the guidelines that outline our professional standards of behavior and practice. It's how we do our job and what we can do and what we're not supposed to do. It's the codes that we have don't make the decisions for us, though. Okay? They just tell us what we do and what's right and wrong. We still have to make our decisions. So we ourselves must interpret and apply our codes to our ethical and ethical decision making. So if you have a home visit, and do ethics say that you can accept a cup of coffee from your client? Your ethics would say no. Now, when you're on your home visit, and it's an older person, and they offer you a cup of coffee, should you say yes or no? You should say yes. ethically, we should say no. Professionally, if we say yes, then we get our information and we can do our job to help them. Because that's all part of the helping for them. In that idea, that's all part of the relationship to help them. If they offer us bond, well, you really can't say no. You can maybe say half, even though you want the whole cookie. If you want the whole cookie, you can have the whole cookie. Yes?
There are instances whereby when you're dealing with an older person, they are insulted if you say no.
Well, exactly. That's my point. So you would want to say yes. Now, that doesn't necessarily mean you have to finish the coffee, even though you're going to finish the bond. Anyway, you can accept the things and say yes to them. It doesn't necessarily mean you have to actually eat them or drink them. You might act like it, but at least for them, they know you're with them.
What if they open a Starbucks?
Then you better hope you haven't had any coffee before, because then you'll be bouncing off the walls. Okay? Remember, Starbucks is 3 times the caffeine, so, ooh, man. They have Starbucks? At home? Anyway. Why did I become a professor anyway? So now, across different codes of ethics, there's some commonalities as far as autonomy of clients and their rights and views. Well, we would respect the rights and views of and clinical practices of other professionals. That's really, really important. And we continue to grow professionally. That's part of what you're doing here today. We consult with other professionals when maybe we were having some issues going on. Maybe we need to get more information. I think part of this, when we get to the end, or part of this, I believe, is agencies working with each other. I think is really important. And I was having a conversation earlier about that in particular, and in some instances, it's unfortunate that what makes it hard to do is money and numbers. So if I have one agency that offers certain type services, and you have an agency, even though there might be different services, I don't want to give you my client, because then I'm giving away my money, unfortunately. But the opposite to that, or well, what might not then, if that's the case, what we might be missing is really helping out clients in the best way by collaborating. But that's something else that we'll come back to. Let's see. Well, last one here is just about adhering to all state laws and state and federal laws, and particularly with confidentiality. So, some ethical principles that we're looking at. There's several principles to look at, but the ones we're pretty much concerned with today are the fourth one here, principle of least harm. We'll talk a little bit more about that. The autonomy and freedom of our clients. The principle of inequality, and also their quality of life. In helping them get better as much as they can get better, depending on their situation, then that's going to improve, hopefully, their quality of life. And in delivering our services, and in doing our interventions or whatever it is that we do with our clients in a way that they're going to accept it, then one, I'm doing no harm. I'm enhancing their autonomy and freedom. But the biggest thing is that I'm improving, or at least helping keep up the quality of life that they have, depending on what that is. Does that make sense? You know, particularly with older adults, they might be in a certain place, and the hope would be that they've accepted where they're at. And if they're at least they're okay with their own situation, well, then it's of course on us to make sure that they're able to at least keep up that as much quality of life as they have, which I believe is something that we would we'd want to focus on. Is everybody culturally competent? The doctor say, yeah, we're all good. Okay, then I'll talk a little bit about it. Actually, I don't think we can. I think we can always. Nothing wrong with it. Reminding. Well, first of all, the other hope that I forgot to preface that I meant to do this is that what I hope is that anything I'm talking about today isn't new. I really hope it isn't, because it's hopefully you already know a lot of stuff that I'm talking about. Okay, and if you did learn something new, great. You know, for those that are getting a review, then great. Nothing wrong with that. That's always a good thing. That's why we have the whole CEU system in place anyway. So now, here's a definition from social work for cultural competence. The process by which individuals and systems respond respectfully and effectively to people of all cultures, languages, classes, races, ethnic backgrounds, religions, and other diversity factors, including but not limited to gender identity and expression, sexual orientation, and marriage or parental partnership status. All in a manner that recognizes, affirms, and values the worth of individuals, families, and communities, and protects and preserves the dignity of each. Easy enough. I think that includes just about every group that we would want to include. We would want to be able to work with any type of client. And one of the things I forgot to say that I meant to say during our discussion of ethics is I pointed out to you values. Professional values and personal values. In my own experience and what I try to teach to students in social work is the more your personal values reflect the values of your profession, the easier time you'll have in working with any type of client. Because then you'll cut down within yourself your own personal ethical dilemmas. Does that make sense? You know, and again, with whatever your values are, they're yours, and you can have them. But what that doesn't guarantee is who I serve as clients, or who becomes my patients. You might have a patient that something about them is against your values, and we don't always have a choice to say to our boss or supervisor, I can't work with that client because of this. Sometimes it's possible, but a lot of times it's not. So if it's not, I don't necessarily have to change my own values, but I just have to understand what are my values as a professional to be able to work with that person. Okay? We don't have to like our clients, we just have to help them. You know, but in helping them, that means treating them as if we like them. Okay, so we don't just so that's one of the things I forgot to tell you about as far as with values. Again, the better the more your personal values reflect your professional values, probably the less stress you'll have, if that's possible. So now. Cultural competence is practical. It's a practical, concrete demonstration of these ethical principles. And I believe I pointed them out a little bit earlier. Respect for persons. Do we want to be respectful for all our clients? Is that going to help us in building rapport and developing that helping relationship? I believe so. Beneficence, doing good. Okay, that's what we're all in this business for. For whatever reason, somewhere in our life, we decided we want to help people, so we ended up here. Okay, and it's good. at whatever level we're at, but we're helping people, and we're learning to do that, and we're just going to get better at that. So we're here to do good. Non-maleficence is not doing any harm. I think, how many times have you heard, first do no harm? And the last one here is justice, treating people fairly. Okay, do we treat patients any different than any others? We shouldn't. We should all treat them equally. And hopefully it's in how we treat our patients, it works and helps them out. But these values here, they're the cornerstones for modern ethical codes for our health professions. Okay. So respect for persons, beneficence or doing good, non-malfeasance, not doing any harm, and justice or treating people fairly. Y'all being treated fairly? You know what I'm going to do? I'm going to make sure I follow the time, so that way you're treated fairly. Oh my. Oops. There are a couple of ethics, on the codes of ethics, there are a couple of places where it does, no, we can wait. You know, there's some students in this room right now thinking it's a good thing that wasn't music. Because I might dance and that might be traumatic for you. And I normally tell my class, okay, at the very beginning, make sure you turn off your cell phones, because if it's music and I dance and you're traumatized, that's my disclaimer. I've told you. Okay, on the Code of Ethics, there are a couple places where it does talk about competence. And we have, with social workers, we're supposed to get education to understand diversity, okay? So we're supposed to do this. We're supposed to be here. It's part of what we're supposed to do. And I'm sure it's not just in a social worker's ethics, okay? Now, diversity, as we can be diverse now in communication, because it's is everything okay? Good. Okay. It's the sign of our times. Okay. It's in 20 years that's going to be commonplace. I don't know if that's good or bad, but okay. Nothing wrong with getting a phone call with you anyway. It's there used to be etiquette. I don't know what that is anymore. But that's a whole other workshop. But we'll write that up. Okay. Okay. So diversity. No. I do not have a problem with you taking the call. I did realize it was probably important, so good. Okay, that's good. I'm talking more about the students, not you.
But I'm not showing a good role model.
That's okay. But everything's good? It was a good call? Well, that's important. Hey, I'm establishing a relationship here. Come on. Okay, good. All right. See, now her stress level has just gone down. Example right there. That would be important. Okay, see, so diversity again refers to individual differences. And these are based on age, gender, identity, race, ethnicity, a lot of different things that we would want to keep into account about our clients. Our clients aren't just, a lot of these things might be on your assessment tools. And they're not just there because it's about demographics. They tell you a lot about your client. And that's something that's really, really important to keep in mind. When we look at, are we in a multicultural world? Big time, okay? we can look back, some of us can look back to 25 years ago when there either wasn't cell phones like we have now, or if there were, no, I'm not picking on you. If there were, the phones were like huge, and you like had to carry like a suitcase around, okay, and plug into a wall or something. But it's something like that wasn't common. That's much more common now than it used to be. That's part of our diversity. That's part of our multiculturalism. Okay, that's my point. So it's even, do all your clients use cell phones? Maybe sometimes some are probably doing that more and more. Even older adults now are doing more texting than they used to. I still am getting used to texting. I only text with my wife because I don't like to do that. It's like, I don't want to talk to anybody like that. Call me on the phone, answer me the question, and hang up. I'll answer, and okay, we're good. If otherwise, I don't want to type all that. See, I'm tired already. Anyway, okay. Let me get to a couple things, and then we'll finish up here. I think we're going to be right on time. There's some values and assumptions that are important to keep in mind. Now, counselors who operate from culturally biased views of mental health and who use interventions that are not congruent with the values of culturally diverse people perpetuate forms of injustice and institutional racism. If I'm not flexible and open to new things, and I'm doing the old things, then I'm becoming a form of injustice and what we would call institutional racism. A lot of the things that we've learned, that we'll learn in school, come from what we would consider Western education. And that's a good thing. That's where we start. But that doesn't mean that's the only thing that we know. Okay, that's maybe the major thing that we know, but then we also would learn to hopefully adapt it. And that's how we become culturally competent. And being able to figure out how to use that with our clients that we have. Ethnocentric bias has been destructive to natural helping giving networks of minority communities, and the failure to incorporate diversity factors into practice, again, is infringing on the client's cultural autonomy. Can we change a client's culture? No. What we can do is welcome their culture and understand their culture, so that then we can work with them and help them get better, instead of making them become one thing. Years and years ago, when our country began, it was called, and some people still like to call it a melting pot, but we're really not a melting pot. If we were a melting pot, then we'd all do the same things, but we all do individual things. We're more actually, and this hasn't changed, we're more culturally pluralist, which means that we keep our own stuff and we can add other stuff and back and forth, instead of just sticking to this one thing, okay? Some biases that we would need to be careful with is neglecting the social and community factors that make us individuals. Using assessment instruments that aren't normed with the population they represent. It's one thing to get a scale that's evidence-based. I had this conversation earlier. I had a really good conversation that just really speaks to what we're talking about today. We can get an evidence-based intervention, but who is it based on? Is it based on the people that I'm working with now, or is it based on a different population in the country? Because there might be evidence for it, and that's great that it works, that it's effective, but is it effective with the clients I'm working with? And if it's not, then why am I using it? So there's a lot more to that, but I won't get into all that. Judging psychopathological behaviors. Is it a diagnosis needed, or is this that their culture? Do I understand their culture before I diagnose them? Okay, a lot of that, of course, is also in the DSM. And again, I just talked about strictly adhering to Western counseling theories. without being open to other stuff. So the degree to which Western values orientations fit from Eastern and other cultures needs to be carefully considered. Okay, so what I learned out of the books after I get my education, now I need to see how do they apply to the populations I work with, and what do I need to know about those populations to then do a better job. Self-disclosure. They maybe at the very beginning they're not going to talk with me. We just talked about self-disclosure in accepting the coffee. But don't accept the coffee, they're not going to disclose. Okay. The whole being direct and directness might be perceived as rude. Maybe I want to, again, be aware of how I approach my client. And also be aware of nonverbal behaviors. I don't want to get too close. If I get too close, or at the same time, maybe a handshake is okay. And maybe it isn't, but just to understand a lot of these things and where they're good and where they're not good. And how it works with my individual client. And you're gonna have whatever your average size of caseload is, then that's how many different clients you're gonna have. Because not everybody's different. So now, some guidelines that we've been again talking about. Recognize that we are cultural beings, that we hold attitudes and beliefs, and that can influence our perceptions of and interactions with individuals who are ethically and radically different than us. Recognize the importance of multicultural sensitivity, responsiveness to, knowledge of, and understanding about ethnic and racially different individuals. We want to learn more about, again, other cultures. Employ constructs of multiculturalism and diversity in our practice. How do we do that? What kind of things do we put in our practice to help? If I'm a Spanish speaker, then that maybe is one thing in working with Spanish-speaking clients. If I'm not totally fluent in Spanish, but I have clients that know Spanish and English, maybe I get to learn some Spanish as I go along. Might be something, as an example. Apply culturally appropriate skills in clinical and other applied practices. And the last one I'll talk about is using organizational change processes to support culturally informed organizational policy development and practice. How, as an agency, are you being culturally competent? What about your agency needs to change, or does it not need it? It may not need to change. It may be that you're on what you're supposed to be. You are doing what we want you to do, and what is culturally appropriate. If you're not, then what can you do to be culturally responsive? Remember, going back to the second slide about not just about services being acceptable. What is going to make those services acceptable? What are you doing to make services acceptable to your clients? Okay. I believe we are at the time for a few questions, if there's any, and then we'll get to the other drawings. But please don't limit your questions because of drawings. Okay. But please, if you have questions, there's a microphone right here too. Oh, I wasn't that clear. Come on. I know it's Friday. I want to go home. Okay then. Well, thank you all very much. I appreciate it.
Thank you. Filled out your participant profile, your statement of attendance. If you do not turn in a statement of attendance, you will not get credit. Period. Of course.
Dr. Gonzalez, on behalf of the Alzheimer's Association and every partner here in this symposium, we would like to present this to you. And this is an art done by an Alzheimer's patient. So thank you so much for your presentation. Thank you for being here. Thank you for making a difference. Thank you.
As I was saying about the paperwork and so on, and of course once again the evaluations. Make sure that you turn that in to the front desk. And of course, without further ado, we'll resume the drawings. Okay, the conference is now concluded. Thank you very much for attending all day. Give yourself a pat on the back. See you next year.